We're recording. It's in progress. All right. So tonight we're going to go over chapter 31, chest injuries. Chapter 31, chest injuries. This is a longer chapter than what we've had, but there's going to be some stuff that I'm not necessarily going to go through. Don't panic, though. Most of it's just like most of it is surveys or what do you call them? Medical and trauma assessments. It's going to be one of those nights, I guess. So we won't go over a whole lot of that because we will go over all that kind of stuff during our boot camp. So if you saw on FISDAP, I set up the boot camp. You may have received messages already talking about that you were assigned to a boot camp for October 9th and 10th. So I went ahead and tried that part out. I was in there messing with FISDAP, trying to get everybody set up or trying to get everything set up for that. If y'all go in there, just go in there and tinker with it. I would say that there's not anything in there that you're gonna break. You know, there's not anything in there that you can break. So if you're tinkering with it or what have you. Now, that being said, that coming from me means absolutely nothing because I'll go in there and tinker with something, break it, and then just move on. And somebody else will figure it out. Somebody much smarter than I am will figure it out. So if you do get in there and ends up getting broke up or something like that, just let me know and we'll try to get something figured out with it. Try to get a workaround. Rob's definitely good at that kind of stuff. So if you break it, he'll more than likely know how to take care of it. Because I definitely break things. So that's just what we do. All right, moving on. All right, so this is what we're going to go over a little bit today. Thoracic injuries, internal bleeding, there's some prevention strategies. Take a gun safety class, sports training, and use your seat belts. I wish I could hit the next button and it would just be like the end. So the thoracic cavity extends from the lower end of the neck to the diaphragm. Any chest injury at or below the nipple line should be considered a thoracic injury and an abdominal injury. The mediastinum is the central region of the thorax that contains the heart, great vessels, the esophagus, lymphatic channels, the trachea, main stem bronchi, and paired vagus and phrenic nerves are in that area as well. So it's the contents of the thorax are partially protected by the ribs, as you can see there. It's connected in the back to the 12 thoracic vertebra and connected in the front through the costal cartilages to the sternum. You can see the sternum. All right. So muscles of the thorax are going to help protect the underlying organs. They provide necessary movement for breathing. The intercostal muscles, which are between the ribs and the diaphragm, are the main muscles of respiration. The sternocleidomastoid muscles are accessory muscles of respiration. The trapezius, rhomboids, and latimus dorsi muscles provide the covering for the framework of the posterior thorax. The pectoralis major surrounds the rib cage of the front. That was me pointing to where everything was at, not me groping myself. The nerves supplying the diaphragm, the phrenic nerves, exit the spinal cord at C3, C4, and C5. All right. All right, we know a lot of this. A lot of this is not unfamiliar to everyone. So cardiac output's defined as the volume of blood delivered to the body in 1 minute. Ventilation is the process of removing CO2. Removing CO2. Went over this in an earlier chapter. Talking about pH ranges. We start getting into acidosis and alkalosis. As you can see, respiratory alkalosis is the result of hyperventilation. Hyperventilation. So acidosis is always related to the body's ability to remove CO2. Changes in arterial pH can modify the respiratory rate and depth. We know that because the body's telling the brain is telling the body, hey, we're not getting enough oxygen, or we're in a state that's not comfortable to us. I have to get that fixed. And so it'll move to that. What do you think that was caused from? That's right, seatbelt. There's a song that I used to sing to my little boy. Actually, my wife started singing it, and then it just kind of stuck in my head about seatbelts. Y'all ever heard it? Seatbelts are our friend. Seatbelts always win. So buckle up and you'll stay in. Seatbelts are our friend. If you got kids, you may have heard that before. But that's what a seatbelt does. They're not always your friend. It's your friend to keep you in, but sometimes friends are abusive. That being one of them. People are looking like, what is he talking about? All right, while I'm talking, I'm going to try and do some rearranging. here. So different types of chest injuries. You got you got open injuries where the chest wall is penetrated by an object. You also have penetrating injuries, which distribute forces over a smaller area. All right, you got blunt trauma, where blunt trauma may fracture the ribs or whole areas of the chest wall. You see there, you got where it could bruise heart and lungs. It can cause damage to the aorta. Some things being like it could bruise that area, or it could cause that area to, I mean, it can literally cause so much damage. It could blow, a thin wall could end up getting tore off. Depending on how it was hit, you can disconnect, or you can have it to where it'll disconnect from its tissue points. And when it disconnects from there, it can it rips and tears some of your major arteries and vessels, which can cause large amounts of problems. All right, blast injuries, they be classified as blunt or penetrating, depending on what's going on. The shock wave is going to be the blunt trauma, and then the secondary phase where the objects are thrown at you are going to be your penetrating trauma. All right, so any injury to the chest has the potential to be lethal. The trauma could result in blood loss. You could have issues where you have pressure changes, vital organ damage, things like that. You can see down there the vascular disruption may occur due to trauma. So rupture of a major vessel can lead to fatal blood loss. And then you have things like a small tear or a blockage can cause a lack of oxygenation and tissue ischemia. Hold on, let me pause for a second. All right, there we go. Mo better. That way now I think I can draw on the screen if I need to. All right. Much better. Can everybody see the PowerPoint again? Did it pop back up? Yes. So you can see the PowerPoint screen. Great. All right. Back to it. All right. So with the pathophysiology, you have you can get bruised lung tissue. It may produce very marked hypoxia as fluid accumulates and impairs gas exchange. Disruption of respiratory tract can prevent oxygen from reaching the alveoli as well. So some signs and symptoms of chest injury. There's some important ones that you need to think about is pain at the site of the injury. Pain that's localized at the site of the injury that is aggravated by breathing, bruising to the chest wall. You'll see that in like that seatbelt incident that you saw there. Crepitus with palpation of the chest. So feeling any type of crepitus when you're starting to palpate that. That's why I tell you it's important to put your hands on your patients, right? Any penetrating chest injury, go figure, right? Dyspnea, you get hemoptysis, hemoptysis. You also have failure of one or both sides of the chest that expand normally with installation, or so what we call sometimes seesaw respirations, or seesaws this way, but you see what do we call it? We used to call it seesaw. It's not called seesaw though, it's called something else. I'll think of it in a minute. But you'll look, and as you're looking along the chest, I'm trying to get lined up here. Somebody will breathe in and you'll see it dip. Okay. You'll see it dip in and it looks like it's seesawing across there. And it's because there's something jacked up with one of the lungs is either collapsed or it's got some sort of serious injury in the chest area. Rapid, weak, and low blood pressures, paradoxical movements. Thank you. Awesome. Thank you, Hannah. Nailed it. Nailed it. And then cyanosis around the lips or nail beds also. Flail chest, that's a good one too. Flail chest. Who can tell me what flail chest is? What makes it flail chest? Look, now I moved the camera. Now y'all can see my junky area. Who can tell me what that is? Flail chest. Does anybody remember? I know y'all remember. Y'all are so smart. There, now it's not as bad. That was probably loud. They're flailing. Ribs dislocate. Yeah, but there's a certain criteria that it has to meet in order to be called a flail chest segment. So it's what criteria does it have to meet in order to be called that? Two or more ribs broken consecutively. Yep. Two or more ribs broken in two or more places consecutively. So it would look a little something like this. I'm going to get to use my pen. Oh my goodness. We're lagging. All right, so that's 2 ribs there. Makes my forehead look even bigger. So this is a rib, and this is a rib. All right, so what we're looking at is you'll have a break. You'll have a break here and here, and then you'll have a break in this next rib here and here. Okay, so these 2 areas are broke up. All right, and that's going to be a flail chest segment. I know, a bunch of 4 head. It's a 5 head. That's so big, it's a 5 head. So after a chest injury, any change in breathing is an important sign. So fewer than 12 breaths a minute or more than 20 breaths a minute may indicate inadequate breathing. And in that case, we need to start work, right? So patients with chest injuries often have tachypnea. Patients with chest injuries often have tachypnea or rapid respirations, right? And shallow respirations. And a lot of times they can be shallow because of pain as well, because taking a full breath hurts. So they'll take smaller breaths a lot of times. So patients may also present with bradypnea, which could be slow respirations and labored respirations, depending on what exactly is going on. What's going on here? After our first break, I'll change into my shirt. All right, so dyspnea. There's many causes, including airway obstruction, damage to the chest wall, improper chest expansion, lung compression. It indicates significant compromise of lung function in an injured patient. So prompt, vigorous support and transport are going to be required for this type of injury. Hemoptysis. I'm going to say it 700 ways. That way I can cover all of them, and one of them should be correct.
Hemoptysis.
Does that sounds good to me? Hemoptysis. So I was right the first time. If I'd have stuck with that. Spitting up or coughing of blood. It indicates the lung. It indicates that the lung parenchyma or the air passages have been damaged, and with a laceration of the lung, blood can enter the bronchial passages as well. That's what they get for having a fireman teach ALS courses. So the presence or absence of a pulse. It's going to vary according to the nature or extent of the injury. A rapid weak pulse or hypotension are signs of hypovolemic shock. Absent radial pulses may indicate severe hypotension. Does anybody remember what we talked about a long time ago about what your systolic blood pressure has to be in order to sustain that radial pulse? So if they're below a certain number of systolic, their systolic number is going to be about what, or below what? 90 or greater to maintain it. Yes. What I usually say is 80. Your systolic is below 80. If you can't feel that, you know it's below 80, which is no bueno. It's 80 tie. $80, 40, and what was femoral? No, it's below 40 if you can't feel it in the carotid. If you can't feel it in the femoral, man, I'm losing a lot of this information. I just taught it a few weeks ago. Bradycardia is going to be a very ominous sign. All right, changes in blood pressure. My algebra grade is much lower than a 70, my friend. Changes in blood pressure. It's going to vary with the extent of the injury. The hypertension may be a result of increased sympathetic discharge. So the patient may also present with hypothermia. It's going to be secondary to neurogenic shock if the injury involves the spinal cord. So be on the lookout for that. So diaphoresis and pallor accompany peripheral vasoconstriction. Cyanosis is a sign of inadequate respiration. They have they're going to be unable to provide sufficient supply of oxygen to the blood. And then this is going to require immediate respiratory support and high flow oxygen if you see this. Many of these signs and symptoms, they can occur simultaneously also. So just be on the lookout. But in any case, if any of these signs resulting from a chest injury, you got to get them, prop transport and aggressive treatment to stay on top of it. Any interruption in the oxygen supply can be rapidly lethal, and it must be treated pretty aggressively. It must be treated very aggressively. Let's say that. All right, so what we talk about that we're going to not do the patient assessment. We'll be doing a lot of those. There's a good picture of JVD. No, man. I got to buy a new computer. That's what I tell my wife anyway. Everybody see that? Somebody does. So if you look on table 31-1, it's going to give you a list of chest injuries called the Deadly Dozen. All right. Let's go ahead and take a 10-minute break, and then we'll come back to this. We've knocked down quite a bit anyway. I'm proud of us.
Grammarly Business is an AI-powered writing assistant, enabling teams around the world to reach their goals faster. Grammarly Business saves time by allowing them to insert custom snippets, which lets them respond to more customers in less time. Grammarly Business also ensures
All right. 10 minutes. I will see y'all in a little bit. It's not weird. You're going to survive it. Kids. He skint up his knee. At school today. It's the nice shirts that Rob got us. Look at that. I think it's huge. Look at that patch. Good Lord. Now I got to work out even harder just so the patch doesn't overtake my entire chest. I'm muted. Unmuted that time. Yeah. Hey, does this mute button work? If I You said yes, you could hear me, or it was muted. It works. Awesome. Interesting. All right. Let's rock and roll. All right, so rib fractures. So rib fracture is going to be infrequent in children because of the pliability of their thoracic cage. They occur most often in elderly patients whose bones may be very brittle. The upper four ribs are well protected by the bony girdle of the clavicle and the scapula. Not scapula, scapula. So a fracture is going to be a sign of a very severe MOI with that. So morbidity and mortality rates are going to increase with age, the number of fractures, and the location of the fractures. So a fractured rib, it can actually lacerate the surface of a lung, which then you would have some pretty big problems. So one of the signs of this is going to be a crackly feeling to the skin and in the area, like a subcutaneous emphysema. That's what that's going to be. Subcutaneous emphysema. It's a crackly feeling in the skin in that area. So what that does, it's indicating that air is escaping from the lung, that lacerated lung, and it's leaking into the subcutaneous layer of the chest wall. So if you do find that, make sure you relay that to the hospital. Rib fractures are most often caused by blunt trauma. And then ribs 4 through 9 are going to be the ones that are most often fractured. They're thinner and they're not very well protected. That's why. So atelectasis, that's going to be a collapse of the alveoli, and it's caused by trauma. Also, it's caused by trauma. It also decreases the surface area for gas exchange. the result is a ventilation and perfusion mismatch. Inadequate perfusion may also cause that mismatch, and it may lead to hypoxia. So severe trauma to the first and second ribs may result in a ruptured aorta, tracheobronchial tree injury, or a vascular injury, because there's a lot of big stuff going on in this area, right? So left lower rib trauma may contribute to a spleen injury, and then right lower rib trauma may contribute to a liver injury. So left, possible spleen, right, possible liver. So multiple rib fractures can lead to atelectasis, hypoventilation, inadequate cough, and pneumonia. The pneumonia mostly because you're not using those your lungs like you should be. And so in the dead space, you'll start to get pneumonia, start to get fluid build up. So with a posterior fracture, the fifth through the ninth ribs are most frequently injured. Lower rib fractures are usually associated with, like we said earlier, spleen, and then kidney injuries as well. The floating ribs are well protected and are very rarely fractured. Injury of those are going to suggest a severe MOI and strong potential for life-threatening injuries as well. So maintain a high index of suspicion even if no visible injury is going on. So most of your patients with fractured ribs are going to localize their tenderness and pain on breathing. So you want to make sure that you administer supplemental oxygen, gently splint the patient's chest, and then if it's permitted by med control, nitrous oxide. I don't think anybody here can give nitrous oxide. Does anybody work for or has worked for an ambulance company that had nitrous oxide on board? I didn't think so. So flail chest. Segment of the chest wall may be detached from the rest of the thoracic cage and produce a free-floating segment, your flail chest, right? It's caused by things like MBCs, falls from significant heights, industrial type incidents, assaults. So significant chest trauma is required to cause a flail chest. So again, the mortality of that is going to increase with advanced age, 7 or more fractured ribs, 3 or more associated injuries, and shock, and then head injuries as well. So breathing with a flail chest is going to be extremely painful and often doesn't allow for adequate oxygenation in that. Respiratory failure in a patient with flail chest generally results from other associated types of injuries. A pulmonary contusion results from a flail chest segment with impaired gas exchange. So the blunt force from it can also cause that pulmonary contusion. And then if the bony fragments go further into the body, then it can cause a pneumothorax or a hemothorax could result from that as well. So with a flail chest, you may have what's called a self-splitting action. It uses the intercostal muscles and purposefully limits the chest wall movement to minimize pain. Your body will do that. So when a flail chest is suspected, you got to expose and examine the chest for what? DCAT BTLS. So typical management of a flail chest is going to be your positive pressure ventilation, then administer oxygen. Assess the need for PPV and then administer oxygen. Sorry. Restricting of the chest wall movement, that's not going to be very well recommended either. They used to teach us to put an IV bag on that side of the chest. Now we teach against that. Sternal fractures, very painful. Tachypnea can be a common finding with this. So don't use overly aggressive ventilations that could further exacerbate injuries. Establish IV access, but provide fluid sparingly if you can. You also want to elevate the head on the long backboard to reduce pressure of the thoracic cavity and facilitate lung expansion as well. So elevate the head on the long backboard, or depending on which side you're calling the head. Clavicle fractures. So most of the time they can be splinted effectively with a sling and slough. Commotio cordis. It's a direct blow during a critical portion of the heart's repolarization phase. Then the result may be immediate cardiac arrest. The death touch. Is that what we're calling that? The epitome of bad timing. Yeah, I would say so. So the affected patient may present with a VFib and responds positively to early defibrillation if provided within the first 3 minutes. So get to it. You know, I wonder if you did the commotio cordis. It's kind of like the precordial thump. Has everybody heard of a precordial thump? Anybody? Nobody? Everybody? So a precordial thump is what you see on TV when these doofuses come up there and they look at the patient. They're like, "Not today, Sonny Jim," or whatever. I don't know if that's. And then they, boom, they hit their chest really hard, and then the patient goes because they're alive because the precordial thump saved their life. So they say that the precordial thump can cause up to a 4 joule electrical impulse, 4 joule electrical impulse. I don't know what the validity of that is, but it can make it to where that little bit of a what's that? Precordial thump. Did I miss something? I missed something, didn't I? And so anyway, and it can bring somebody out of cardiac arrest or VFib or whatever. So I wonder whether commotio cordis is just like a precordial thump. I wonder if you gave another precordial thump, would it bring them out of VFib and back into a normal sinus rhythm, or anything different? All right, simple pneumothorax. It's going to be a condition where air enters through a hole in the chest wall or surface of the lung as the patient attempts to breathe. So pressure continues to build up in the pleural space. Try to draw it again. So in this area, the pleural space, the larger the hole, the more rapidly the lung's going to collapse. Makes sense, right? And then there may be only a small accumulation of air, and pulmonary function may remain adequate. The internal wound is going to allow air to enter the pleural space, like we talked about. And small tears may also seal themselves, while larger ones may progress. We talked about there covering open wounds. Ooh, chest wall movement decreases, pressure increases, and hyperresonance can be detected with percussion. Who remembers what percussion is? Most of the time we do percussion when we're doing stomach and we're doing abdominal assessments. Not stomach assessments, abdominal assessments. But they're talking about doing for chest assessments. Pretty snazzy. Open pneumothorax. It's going to occur with penetrating trauma to the chest. There's going to be profound hypoventilation is going to can result. Death may occur if it's not cared for quickly or if you delay in that care. And then hypoxia occurs as less gas exchange is available for gas, or less oxygen is available for gas exchange. Either way, it's not good. So there's a good photo of, there's a good drawing of open pneumothorax. What are we going to use on that? Does anybody remember a heat seal? What is a heat seal? Chest seal. That's better. Chest seal. What does this patient really need? Yeah. Jesus. Yep. I need a chest tube. That's pretty good. I need Jesus. Yep. So a chest tube, yes. In the field, the best you could hope for is chest needle decompression. Oh, but you could call somebody that can. You can intercept somebody that can. Do we still do three-sided occlusive dressings anymore?
I thought we had to burp it.
Yes. Has anybody in here ever done one?
No.
They suck. they do suck. So it hasn't really been proven that they're as effective as they make them out to be. Yeah, I know. And a lot of people are taught. I was taught to do three-sided occlusive dressings, but now they're leaning more towards the definitive chest needle decompression and four-sided occlusive dressings. So I know they're leaning more towards that. I need to get another look on this because I know in medical school they don't teach it anymore. They tell us not to do it, and then in TCCC they teach us not to do it. But they give us chest seals. They give us Asherman's, and they give us what's the other, the hyphen chest seals as well. They give us those. I actually have one of those somewhere. But yeah, they're teaching us to do four-sided for the most part. But yeah, to burp it, all you would do is, every now and then you got to stick your finger in there and burp it out. But I think there was a big deal that it not working as well as they thought it would. I'm a type. It's kind of like CPR. CPR, if it saved one person, it's done its job. I mean, how many times has anybody in here done CPR and it been successful? It has a very low success rate. CPR itself does. Now, the other things that come with it may do better, such as the drugs that go with it and everything else. I know AMR South Mississippi at one point, the national average was like in the high teens percentage wise of success during CPR, cardiac arrest, and CPR ensued. It was like in the high teens. And South Mississippi AMR, it was actually 30% at one point. Now, given it said South Mississippi AMR, it was probably because of the squad truck out in the county is probably what did it. If we had to wait on AMR to show up, nobody would survive. I'm just giving the AMR guys a hard time. The one AMR. Yeah, well, Hannah, you now too. Well, that and, running your code. I think we ran more codes for AMR. And I actually had one of the AMR medics tell me, he was like, we love coming out to the county. Everything's already done when we get here. They better not be lazy. Oh, who is the AMR medics that come out? Yeah, they're using, look at this in this picture here. Does anybody remember what this one's called? What this chest seal is called? Come on, work, you pig. There we go. It's HCFR. HCFR. Does anybody remember what this one's called? This is the Asherman's, right? Yeah. Well, it depends on what shift you're on or who's running squad, who's on the squad whenever you're out there. If it's Donnie, then there's your problem. He quit coming to our classes. I guess that means he passed registry, maybe, or gave up. I don't know. I'll have to call him. But now, how could you not get along with any of the Harrison County guys? All they do is help y'all out. Well, I mean, it's kind of y'all's job to give supplies. We're a team. Hold on, I'm texting Donnie. Not that Donnie. Yep. There you go. So it doesn't, so now it's giving you the choice of whether 3-sided or 4-sided. Interesting. But if you see if you do see a penetration in the chest, what are we looking for? What else are we looking for? If you see a penetration on one side, depending on the type of injury, you should be looking for an exit or anything else as well, right? You never know where it came from. Unless you know where it came from. And that is what we call critical thinking. You guys are all very well capable of that. So tension pneumothorax. Why do we call it tension pneumothorax? What does the tension part of it mean? Very simple. Pressure on the what? Yep, pressure on the heart. That's all that means. All right, so tension pneumothorax, pressure on the heart. One of the things that we're looking for is pulsus paradoxus. Does anybody remember what pulsus paradoxus is? That's right. Well, heart, lung, tomato. No, I thought you were giving me an answer. Pulsus paradoxus. You feel the radial pulses or what have you. One is different than the other, right? One is going to be have a different feeling than the other. That's right. All right. And that's why also tachycardia and dysrhythmias may be an issue. Unequal chest rise, we're going to know that because it's collapsed. It's all the way collapsed, and now it's creating pressure into the mediastinum. So it's creating pressure on the heart. So tension pneumothorax means tension on the heart. It's pushing on the heart.
So I know this is a dumb question, but can you refresh my memory of the difference between dysrhythmia and arrhythmia?
Yes. So first off, there are no dumb questions, just dumb people. Second off, your dysrhythmias and arrhythmias, arrhythmia means what? A always means what?
Without
Dys meaning it's not functioning.
shortness of
yeah, something to that effect. But when we're talking about an arrhythmia or a dysrhythmia, it could be the same. You can have an arrhythmia and you can have a dysrhythmia also. I would say that you can interchange them, because a lot of the things that they say is deadly arrhythmias, but then I've also heard deadly dysrhythmias. So I would say that you can use them interchangeably. So now when you talk about dysrhythmias or arrhythmias, it's those are electrical in nature. They're electrical in nature. So that's where you're going to get into that's where you would see on a 12 lead or a 4 lead or something like that, you would see some sort of an electrical change in there that would cause that. Tachycardia is considered a mechanical issue. Possibly. That's a mechanical function. Sorry, not a mechanical issue, but a mechanical function. Now there you are getting faster pulses, but they're going to be at a regular rate. Tachycardia just means fast, and it's going to be at a regular rate. Whereas if it were a dysrhythmia, it would not be at a regular rate. Or an arrhythmia, meaning that it would be absence of a rate. There's some sort of rate, some sort of what have you. A and dys. I've always used them interchangeably. Nobody's ever corrected me on it. I'm sure somebody way smarter than I am would probably correct me on it one day. Ty, you want to give it a shot? Are you Googling it now? You're way smarter than I am. The guy that just wrote heart, lung, tomato, tomato. Yeah, it'd be an arrhythmia then. AFib being atrial fibrillation. There's an electrical issue there. Watch now somebody's gonna be like, no, you're wrong, Colonel Sanders. So I asked Donnie if he passed registry yet. He hadn't let me know anything. Aha. So I was right. I Googled it. I'm not afraid to say that. So the term dysrhythmia and arrhythmia differ mainly in a linguistic sense. Dys is a Greek prefix meaning bad or ill, hard or difficult. A is another Greek prefix that generally means not or without. Therefore, dysrhythmia essentially means a bad rhythm. Arrhythmia basically means without rhythm. So right there, we hit it, right? As nouns, the difference between arrhythmia and dysrhythmia is that arrhythmia is an irregular heartbeat, while dysrhythmia is a disturbance to an otherwise normal rhythm, especially in the heart. So sounds like pretty well the same to me. Is that good? Google told me. I GTS'd it. So hemothorax. So it's a hemothorax. Instead of air, it's what? Blood, right? Instead of air, you're going to have blood. So definitely need a chest tube for that. Accumulation of more than 1,500 milliliters of blood within the pleural space. That's a lot of blood, unfortunately. So you can get into decompensated shock from bleeding out inside your chest cavity. So you can expect to find with some of this stuff is like your tachypnea, because now they're hypovolemic, plus they're having those chest issues, lung issues. They're going to be tachycardic, hypovolemia issued, dyspnea, self-explanatory. All of this pretty much is respiratory distress, hypotension, narrowed pulse pressures. So look for that, narrowed pulse pressures. And then pleuritic chest pain, pale, cool, moist skin, dullness, unequal. So it's like hypovolemia. It's like the same signs and symptoms of hypovolemia for this chest injury for hemothorax. So ABCs, give a fluid bolus. You do not increase the blood pressure past the point of maintaining perfusion. That's something that I always want to harp on is we're not trying to resume a normal blood pressure in a lot of these patients that are in that danger zone area. We want to maintain just past the point of perfusion. And that is where we say keep them above, they're systolic of above what, 90? Besides that, and if they're hypovolemic to a heavy extent, then you're like they're insanguinating or what have you, then all you're doing is replacing blood with water or with normal saline, and you're just making Kool-Aid. So we went over pulmonary contusions earlier. So upon auscultation, you may reveal different things like wheezes, rhonchi, rales, diminished breath sounds in the affective area. So something that's not good for it, hypoxia and carbon dioxide retention can lead to the respiratory distress, this dyspnea, tachypnea, agitation, and also restlessness as well. So don't overhydrate the patient either. Give only small amounts of fluid bolus or IV fluid, sorry, and to improve cardiac output, which we talked about, 90, right? So cardiac tamponade, so also known as pericardial tamponade. It's relatively uncommon in this instance. What does this person need? Anybody remember the what it is they need? We can't give it to them, but they need it. So what they need is pericardial. They need me to know how to work a computer. Pericardial synthesis, which means Donnie says he finishes his last ride along next month. Boy, it's taking him forever. Stretching that thing out. Telling you, get your ride-alongs finished quickly. That way you can go take your registry. Finish your ride-alongs quickly. Don't hold off on that. So he said it's been difficult getting the sticks. Difficult getting sticks. I don't know if that means that it's been difficult to get patients with sticks, which I don't know why. Or has it been difficult, like he's been missing the sticks? I don't know. But that's why it's important for you to take every opportunity you have. Don't pass up on it. Any patient, just be like, hey, can I stick them? So it says there, the space between the layers can hold 30 to 50 milliliters of fluid, and it can slowly distend with as much as 1,000 to 1,500 milliliters of blood or other fluid in there as well. Fireman. So tells you to initiate a large bore IV access and provide rapid fluid bolus to maintain systolic blood pressure of 80 to 90 millimeters of mercury. Rapid transport. So you got a table 31-2 that's going to give you your physical findings of tamponade, cardiac tamponade. So myocardial contusion is going to be bruising of the heart, right? It may occur because of blunt trauma. The fibrinous reaction at the contusion site may lead to a delayed rupture or a ventricular aneurysm even. So clinical signs will be varied based on the area of the injury. Some associated injuries could be one to three rib fractures, as well as a sternal fracture also. So some of these patients may present with what's called retrosternal chest pain. And then often the pulse rate is going to be irregular also. So the life-threatening rhythms such as a ventricular tachycardia and ventricular fibrillation are they're uncommon with it, but the pulse rate may be irregular. So establish that IV access, assess for JVD, jugular vein distension, and also pulmonary edema. Call for a paramedic backup. Do it to it. And then you want to make sure that you monitor for rapid deterioration as well. So a myocardial rupture is not going to be very good. So severe blunt force compresses the heart between the sternum and the vertebra. Penetrating injury of the heart, a foreign object or a bony fragment is propelled into the heart. It's a life-threatening event. Patients may present with acute pulmonary edema or signs of cardiac tamponade. All right, so traumatic aortic disruption. We talked about that earlier. So rupture of the aorta occurs most often in blunt force trauma as a result of MVCs and falls. So the aorta is going to rupture. It occurs when the aortic aneurysm bursts, an aneurysm in there if it bursts. So fewer than 1/3 of the patients with either type of traumatic aortic disruption survive 3 days or longer. 3 days or longer. So got a high mortality rate, high morbidity rate. So a high percentage of patients also have no signs of external chest trauma with this either. So a lot of times you'll hear them say they felt a tearing in their back, or they feel a severe burning in their back. You'll hear that. So the retrosternal or interscapular pain is going to be described as a tearing, as it says there. That's what they're talking about, the retrosternal pain. .44 mag point blank did it for a guy in Biloxi. Yeah, I would think so. I don't know if you remember in the last county we worked together in, we had a patient that was shot in the chest with a .270. Were you on that one? Yeah, so that was I can't remember if it was me, and it might have been Tony. It was either me or Tony, or me or Mike, one of the two. But yeah, that was a bad one. That pretty much did it for him too, and me, because I had to do compressions for 45 minutes all the way to Highland, redonkulous. That's been a long time ago. What was Tony's last name? Do you remember that? I don't remember it either. Hosey. That's right. Hosey. Tommy. Wait. Tommy? Is it Tommy? I thought it was Tony. Tommy Hosey. Okay. Been there for a long time. African American guy. Is that correct? Are we talking about the same person? Yep, that's him. Tommy Hosey. I'm gonna write that down. I was talking about him the other day. Yep. Well, I don't know. Shorts, that's relative. Perry County. Holy cow. Why? I can't believe he's still working over there. Is Mike still working out there? I remember he did have some sort of event. Yeah. Yeah, I remember that. I know he likes to fish. He needs to retire and start doing more of that. I wouldn't doubt it. Yeah, that does sound quite messy. I'm going to go out on a limb here and say that he probably didn't make it. If he made it, that's very surprising. Yeah. Yeah, I don't doubt he's no longer married either. Working as much as he did. Yeah. So diaphragmatic injuries may be the result of blunt or chest trauma or penetrating trauma, I mean. So the healing process is inhibited by the natural pressure differences between the abdominal and thoracic cavities. Diaphragmatic injuries. So it can be life-threatening, and high pressure compression to the abdomen results in an increase in intra-abdominal pressure and can lead to it. So a lot of times you'll have the diaphragmatic injury, and like sometimes the stomach or something like that will poke through the hole because of the pressure difference. And that's when it becomes very painful. But it can lead to a bowel obstruction or a strangulation because it gets poked through the hole. And it can also lead to restricted lung expansion because remember, that's part of the reason why you breathe is your diaphragm. But one of the rare complications of it is that you can actually have the abdominal contents end up in the thoracic cavity. Wicked. So a Gastro Thorax is resulting increased intrathoracic pressure, both compresses the lung on the effective side and it compromises circulatory function. So some signs and symptoms, it may be subtle, but it can include tachypnea, tachycardia, well, they're listed right here. You guys can read just as well as I can. They're over there. You want to elevate the head on the backboard to keep the abdominal contents in the abdominal cavity. It may help. And then do positive pressure for hypoventilation. So an esophageal injury. So penetrating trauma is the most frequent. It's rare in blunt trauma. So you can have a spontaneous issue, or excuse me, a spontaneous perforation. So like violent emesis, carcinoma, anatomic distortions produced by diverticular or gastric reflux. We've talked about alcoholics that can wind up having it, and that in which that you get an esophageal varices as well too because of that. Everything's weakened. So there's what they typically present with. So there are some signs to a cervical esophageal perforation. So if the perforation is in the intrathoracic, I have no clue what just happened. That was weird. If the perforation is in the intrathoracic esophagus, some signs that it could include is like your mediastinal emphysema, mediastinitis, subcutaneous emphysema. We talked about that, the crackling feeling because there's air in there. Splinting of the chest wall. And then the pre-hospital care for it's going to be supportive. So you just got to manage the patient's symptoms as they come. So tracheobronchial injuries, they're rare. Usually because of blunt or penetrating trauma. They have a very high mortality rate. The site of the injury is often close to a point of attachment. The injury to the trachea or the main stem bronchi allows for rapid movement of air into the pleural space. So not good. So there's a list of findings. So early recognition and rapid transport are going to be the key to managing that tracheobronchial injury. So you want to treat the patient symptomatically, position appropriately, and ventilate as needed. So traumatic asphyxia. It's a sudden compression you see in a lot of your compression trauma patients. So it's going to produce a rapid decrease in intrathoracic pressure. There's a picture of it there. It's like being squeezed like a balloon. You squeeze that balloon and it just at the top, your eyes can bulge out, all that stuff. Yeah, a lot of times you'll see the distended neck veins, which you should. It's pulsed out. So below the area, you're going to see normal color. Hypotension occurs when the pressure is released. And then early recognition and rapid transport are going to be the key in this one as well. Treat symptoms, position appropriately as you can, ventilate as needed. And then definitely take cervical spine precautions with this patient and obtain that IV access. Large bore IVs. All right. Do we have any questions about anything that we've been over tonight? There is our code there, 6878. That's the magic code to get you into the test. Also, I know what I didn't talk about. 6878. 6878. All right, let me see here. Has everybody logged into FISDAP yet? I see everybody's put in, but has everybody logged into it and just kind of taken a self-guided tour, a 3-hour tour? Awesome. All right, so if everybody can see this here, I got you an assignment. Along with your quiz, the assignment will be due next Wednesday. So I got here, soon you'll be participating in ride-alongs. What are the expectations of the preceptors? What can you do? What can you not do? What will you document? What will you wear? Everything like that. If you have any questions about what you will wear, then let me know. And so on this assignment, what I'm really looking for is, I'm looking for the information, yes, that you see there listed. But what I'm also looking for is your preceptor's point of contact. And they'll get my point of contact as well. And then more importantly, I want to know what your expectations of your preceptors are. And what that means is like, what do you expect for your preceptor to teach you? Or how do you expect for your preceptor to what type of training are you looking for your preceptor? Because you know what works effectively for you to learn. You know, is it muscle memory? Is it talking things out? Is it reading things? What helps you learn? And I want you to be able to express this to your preceptor. Hey, this is kind of what I'm looking for in this. And then also ask your preceptor, and this won't be a part of the writing part of the assignment, but ask your preceptor what they expect of you. Now, most of them are like, to jump in there. We expect you to jump in there and start working. I expect you to do this, you know, and then that way, you know what their expectations are, and you can work well with that preceptor. A lot of time, if you're a reserved person that kind of steps back and you don't really jump into things, then you're gonna have to climb over that obstacle. You're gonna have to put yourself out there. You're gonna have to be aggressive and get in there with those patients. No, so you're gonna have to be aggressive with those patients, or be aggressive with those scenes, and really jump in there. Maybe almost overly enthusiastic to an extent, because you're trying to learn. You're a student, you know, so ask questions. That's one good thing. Preceptors, they love that. If you ask questions, I know when I was precepting, I want you to ask me questions. I want you to challenge me. I want you to jump in there. I want you to ask for patients. You know, I want you to ask for that stick. I want you to ask for that procedure. Ask for it. And then also, that's the best time to really get your documentation down. Your patient assessments, yes, to get that down, use the process. You may feel like it's corny or embarrassing or what have you, but if you're using the process, you are not going to fail. I still use the same process. As I did. Now I've honed it. It sounds a lot better, but I go through the list just as I did whenever I was in paramedic school. Because it works, and I use that process every single time without fail. And like I said, I've honed it, but I do it so much that I've had the ability to hone it. I've had the experience to be able to do that. But if you were to take my assessment and break it down, you could almost go down the list and see that I would pass that registry practical exam every time. So make sure you're following that. It's going to make you a better ALS provider if you do that, because you will do the same thing every time. You will be very consistent in that fact. What it'll also help you is that you will pass your practical portion, or your psychomotor portion of your NREMT like that. You're not going to have any issues. So make sure that you're looking over that, because now you're about to get into the real deals, right? Don't be afraid to jump in there. I want you to know your scope of practice, because I want you to fulfill it. I want you to be able to use all of it if you have the opportunity to. Okay. Now is the best time. That if you're going to make a mistake now, it's the best time to do it before you get out there on the truck and make a mistake out there. They're not going, I say this, me as a preceptor, I'm not going to let you kill anybody. Okay. But it's also important that if you're giving medications, that you're making those announcements. Hey, he weighs this much, I'm going to give him this. Or even IVs. Don't just stick him and then roll a bolus, you know. Say that. Say, hey, I expect that the patient he weighs 200 pounds, and I'm going to give 200 pound or 20 milliliters per kg, you know, take that 200 pounds and then estimate it, or put that into kgs and then give him his 20 milliliters per kg. Or if he's a child, 10 milliliters per kg, or what have you, you know, make sure you have those numbers down. That's going to help you commit it to memory. Because after this assignment, and after we get the medications and all that good stuff, after this assignment, I'm going to have you do medication cards. And the medication cards are going to be the small little cards, and you'll carry them with you. And that's what's going to help pound that into your head. You're constantly going to look at that kind of stuff. I'm going to try not to beat on you too much with tests and all that good stuff. It'll mainly be once you get into your ride-alongs pretty regularly, most of your assignments and stuff will start to be more geared towards your on-the-job training or your training, your practical type training. Okay. We're about to hit up a lot of trauma. You see it now. We're starting to a lot of trauma stuff. We're about to hit up into a lot of this stuff that's going to require your skill in doing your assessments and your field diagnosis and your treatments. So I'm going to start trying to set up the training more towards that. Okay. Does anybody have any questions about anything you read here? All right, I'm going to stop recording.